This reading is about Why Doctors Should Intervene by Terrence F. Ackerman, found in the Hastings Center Report, Volume 12, Number 4, published August 1982, by the Hastings Center. Read by Rigo Martinez. Why Doctors Should Intervene. Patient autonomy has become a watchword of the medical profession. According to the revised 1980 AMA Principles of Medical Ethics, no longer is it permissible for a doctor to withhold information from a patient, even on the grounds that it may be harmful. Instead, the patient is expected to deal honestly with patients. Instead, the physician is expected to deal honestly with patients at all times. Physicians also have a duty to respect the confidentiality of the doctor-patient relationship. Even when disclosure to a third party may be in the patient's interest, the doctor is instructed to release information only when required by law. Respect for the autonomy of patients has given rise to many specific patient rights. Among them, the right to refuse treatment, the right to give informed consent, the right to privacy, and the right to competent medical care provided with respect for human dignity. While requirements of honesty, confidentiality, and patients' rights are all important, the underlying moral vision that places exclusive emphasis upon these factors is more troublesome. The profession's notion of respect for autonomy makes non-interference an essential feature. As the Belmont Report has described it, there is an obligation to give weight to autonomous persons' considered opinions and choices while refraining from obstructing their actions unless they are clearly detrimental to others. Or as Tom Beauchamp and James Childress have suggested, to respect autonomous agents is to recognize with due appreciation their own considered value judgments and outlooks, even when it is believed that their judgments are mistaken. They argue that people are entitled to autonomous determination without limitation on their liberty being imposed by others. When respect for personal autonomy is understood as non-interference, the physician's role is dramatically simplified. The doctor need be only an honest and good technician, providing relevant information and dispensing professionally competent care. Does non-interference really respect patient autonomy? I maintain that it does not, because it fails to take account of the transforming effects of illness. Autonomy, typically defined as self-governance, has two key features. First, autonomous behavior is governed by plans of action that have been formulated through deliberation or reflection. This deliberative activity involves processes of both information gathering and priority setting. Second, autonomous behavior issues intentionally and voluntarily from choices people make based upon their own life plans. But various kinds of constraints can impede autonomous behavior. There are physical constraints. Confinement in prison is an example, where internal or external circumstances bodily prevent a person from deliberating adequately or acting on life plans. Cognitive constraints derive from either a lack of information or inability to understand that information. A consumer's ignorance regarding the merits or defects of a particular product fits the description. Psychological constraints, such as anxiety or depression, also inhibit adequate deliberation. Finally, there are social constraints such as institutionalized roles and expectations. For example, a woman's place is in the home. The doctor knows best. That block considered choices. Edmund Pellegrino suggests several ways in which autonomy is specifically compromised by illness. In illness, the body is interposed between us and reality. It impedes our choices and actions and is no longer fully responsive. Illness forces a reappraisal and that possess a threat to the old image. It opens up all the old anxieties and imposes new ones, often including the real threat of death or drastic alterations in lifestyle. This ontological assault is aggravated by the loss of freedoms we identify as peculiarly human. The patient lacks the knowledge and skills necessary to cure himself or gain relief of pain and suffering. The state of being ill is therefore a state of wounded humanity, of a person compromised in his fundamental capacity to deal with his vulnerability. The most obvious impediment is that illness interposes the body of or mind between the patient and reality, obstructing attempts to act upon cherished plans. An illness may not only temporarily obstruct long range goals, it may necessitate permanent and drastic revision in the patient's major activities, such as working habits. Patients may also need to set limited goals regarding control of pain, alteration in diet and physical activity, and rehabilitation of functional impairments. They may face considerable difficulties in identifying realistic and productive aims. The crisis is aggravated by a cognitive constraint, the lack of knowledge and skills to overcome their physical or mental impediment. Without adequate medical understanding, the patient cannot assess his or her condition accurately. Thus, the choice of goals is seriously hampered, and subsequent decisions by the patient are not well founded. Pellegrino mentions the anxieties created by illness, but psychological constraints may also include denial, depression, guilt, and fear. I recently visited an 18-year-old boy who was dying of a cancer that had extensively throughout his abdomen, that had metastasized extensively throughout his abdomen. The doctor wanted to administer further chemotherapy that might extend the patient's life a few months. But the patient's nutritional status was poor and he would need intravenous feedings prior to chemotherapy. Since the nutritional therapy might also encourage tumor growth, leading to a blockage of the gastrointestinal tract, the physician carefully explained the options and the risk and benefits several times, each time at greater length. But after each explanation, the young man would say only that he wished to do whatever was necessary to get better. Denial prevented him from exploring the alternatives. Similarly, depression can lead patients to make choices that are not in harmony with their life plans. Recently, a middle aged woman with a history of ovarian cancer in remission returned to the hospital for the biopsy of a possible pulmonary metastasis. Complications ensued, and she required the use of an artificial respirator for several days. She became severely depressed and soon refused further treatment. The behavior was entirely out of character with her previous full commitment to treatment. Full supporting, Fully supporting her overt wishes might have robbed her of many months of relatively comfortable life in the midst of a very supportive family around which her activities centered. The medical staff stalled for time. Fortunately, her condition improved. Fear may also cripple the ability of patients to choose. Another patient, diagnosed as having a cerebral tumor that was probably malignant, refused life saving surgery because he feared the cosmetic effects of neurosurgery and the possibility of neurological damage. After he became comatose and new evidence suggested that the tumor might be benign, his family agreed to surgery and a benign tumor was removed. But he later died of complications related to the unfortunate delay in surgery. Although while competent, he had agreed to chemotherapy, his fears prevented him from accepting the medical intervention that might have secured him the health he desired. Social constraints may also prevent patients from acting upon their considered choices. A recent case involved a 12-year-old boy whose rhabdomyosarcoma had metastasized extensively. Since all therapeutic interventions had failed, the only remaining option was to involve him in a phase 1 clinical trial. A phase 1 clinical trial is the initial testing of a drug in human subjects. Its primary purpose is to identify toxicities rather than to evaluate therapeutic effectiveness. The patient's course had been very stormy, and he privately expressed to the staff his desire to quit further therapy and return home. However, his patients denied the hopelessness of his condition, remaining steadfast in their belief that God would save their child. With, with deep regard for his parents' wishes, he refused to openly object to their desires, and the therapy was administered. No anti-tumor effect occurred, and the patient soon died. Various social and cultural expectations also take their toll. According to Talcott Parsons, one feature of the sick role is that the ill person is obligated to seek technically competent help, namely, in the most usual case, that of a physician, and to cooperate with him in the process of trying to get well. Parsons does not describe in detail the elements of this cooperation, but clinical observations suggest that many patients relinquish their opportunity to deliberate and make choices regarding treatment in deference to the physician's superior educational achievement and social status. The physical and emotional demands of illness reinforce this behavior. Moreover, this perception of the sick role has been socially taught from childhood, and it is not easily altered even by the physician who ardently tries to engage the patient in decision making. Indeed, when patients are initially asked to participate in the decision making process, some exhibit considerable confusion and anxiety. Thus, for many persons, the institutional role of patient requires the physician to assume the responsibilities of making decisions. Ethicists typically condemn paternalistic practices in the therapeutic relationship, but fail to investigate the features that incline physicians to be paternalistic. Such behavior may be one way to assist persons whose autonomous behavior has been impaired by illness. Of course, it is an open moral question whether the constraints imposed by illness ought to be addressed in such a way, but only by coming to grips with the psychological and social dimensions of illness can we discuss how physicians can best respect persons who are patients. Returning control to patients. In the usual interpretation of respect for personal autonomy, non interference is fundamental. In the medical setting, this means providing adequate information and competent care that accords with the patient's wishes. But if serious constraints upon autonomous behavior are intrinsic to the state of being ill, then non interference is not the best course, since the patient's choice will be seriously limited. Under these conditions, real respect for autonomy entails a more inclusive understanding of the relationship between patients and physicians, rather than restraining themselves so that patients can exercise whatever autonomy they retain in illness. Physicians should actively seek to neutralize the impediments that interfere with patients' choices. In the healer's, in the healer's art, Eric Cassell underscored the essential feature of illness that demands a revision in our understanding of respect for autonomy. If I had to pick the aspect of illness that is most destructive to the sick, I would choose the loss of control. Maintaining control over oneself is so vital to all of us that one might see all the other phenomena of illness as doing harm not only in their own right, but doubly so, as they reinforce the sick person's perception that he is no longer in control. Cassell maintains the doctor's job is to return control to his patient, but what is involved in returning control to patients? Pellegrino identifies two elements that are preeminent duties of the physician: to provide technically competent care and to fully inform the patient. The non interference approach emphasizes these factors, and their importance is clear. Loss of control in illness is precipitated by a physician or mental defect. If technically competent therapy can fully restore previous health, then the patient will again be in control. Consider a patient who is treated with antibiotics for a routine throat infection of strepto- streptococcal origin. Similarly, loss of control is fueled by lack of knowledge, not knowing what is the matter, what it portends for life and limb, and how it might be dealt with. Providing information that will enable the patient to make decisions and adjust goals enhances personal control. If physical and cognitive constraints were the only impediments to autonomous behavior, then Pellegrino's suggestions might be adequate. But providing information and technically competent care will not do much to alter psychological or social impediments. Pellegrino does not adequately portray the physician's role in ameliorating these. How can a doctor offset the acute denial that prevented the adolescent patient from assessing the benefits and risk of intravenous feedings prior to his additional chemotherapy? How can he deal with the candidate for neurosurgery who clearly desired that attempts be made to restore his health, but feared cosmetic and functional impairments? Here, strategies must go beyond the mere provision of information. Crucial information may have to be repeatedly shared with patients. Features of the situation that the patient has brushed over, as in denial, or falsely emphasized, as with acute anxiety, must be discussed in more detail or set in their proper perspective. And the physician may have to alter the tone of discussions with the patient, emphasizing a positive attitude with the overly depressed or anxious patient, or a more realistic, cautious attitude with the denying patient in order to neutralize psychological constraints. The physician may also need to influence the beliefs of or attitudes of other people, such as family members, that limit their awareness of the patient's perspective. Such a strategy might have helped the parents of the dying child to conform with the patient's wishes. On the other hand, physicians may need to modify the patient's own understanding of the sick role. For example, they may need to convey that the choice of treatment depends not merely upon the physician's technical assessment, but on the quality of life and personal goals that the patient desires. Once we admit that psychological and social constraints impair patients' autonomy, it follows that physicians must carefully assess the psychological and social profiles and needs of patients. Thus, Pedro, Lane, and Trago insist that adequate therapeutic interaction consists in a combination of objectivity and cooperation. Cooperation is shown by psychologically reproducing in the mind of the doctor, insofar as that is possible, the meaning the patient's illness has for him. Without such knowledge, the physician cannot assist patients in restoring control of their lives. Ironically, some critics have insisted that physicians are not justified in acting for the well being of patients because they possess no expertise in securing the requisite knowledge about the patient, but knowledge of the patient's psychological and social situation is also necessary to help the patient to act as a fully autonomous person. Beyond legalism, current notions of respect for autonomy are undergirded by a legal model of doctor patient interaction. The relationship is viewed as a typical commodity exchange. the provision of technically competent medical care in return for financial compensation. Moreover, physicians and patients are presumed to have an equal ability to work out the details of therapy, provided that certain moral rights of patients are recognized. But the compromising effects of illness, the superior knowledge of physicians, and the various institutional arrangements are also viewed as giving the physician an unfair power advantage. Since the values and interests of patients may conflict with those of the physician, the emphasis is placed upon non interference. This legal framework is insufficient for medical ethics because it fails to recognize the impact of illness upon autonomous behavior, even if the rights to receive adequate information and to provide consent are secured. Effective and social constraints impair the ability of patients to engage in contractual therapeutic relationships. When people are sick, the focus upon equality is temporarily misplaced. The goal of the therapeutic relationship is the development of the patient, helping to resolve the underlying physical or mental defect, and to deal with cognitive, psychological, and social constraints in order to restore autonomous functioning. In this sense, the doctor patient interaction is not unlike the parent child or teacher student relationship. The legal model also falls short because the therapeutic relationship is not a typical commodity exchange in which the parties use each other to accomplish mutually compatible goals without taking a direct interest in each other. Rather, the status of patients as persons whose autonomy is compromised constitutes the very stuff of therapeutic art. The physician is attempting to alter the fundamental ability of patients to carry through their life plans. To accomplish this delicate task requires a personal knowledge about and interest in the patient. If we accept these points, then we must reject the narrow focus of medical ethics upon non interference and emphasize patterns of interaction that free patients from constraints upon autonomy. I hasten to add that I am criticizing the legal model only as a complete moral framework for therapeutic interaction, as case studies in medical ethics suggest. Physicians and patients are potentially adversaries. Moreover, the disability of the patient and various institutional controls provide physicians with a distinct power advantage that can be abused. Thus, a legitimate function of medical ethics is to formulate conditions that assure non interference in patient decision making. But various positive interventions must also be emphasized, since the central task in the therapeutic process is assisting patients to reestablish control over their own lives. In the last analysis, the crucial matter is how we view the patient who enters into the therapeutic relationship. Cassell points out that in the typical view, the person is seen simply as a well person with a disease, rather than a qualitatively different, not only physically, but also socially, emotionally, and even cognitively. In this view, the physician's role in the care of the sick is primarily the application of technology, and health can be seen as a commodity. But if, as I believe, illness renders sick persons qualitatively different, then respect for personal autonomy requires a therapeutic interaction considerable more complex than the non interference strategy. Thus, the current principles of medical ethics simply exhort physicians to be honest. But the crucial requirement is that physicians tell the truth in a way, at a time, and in whatever increments are necessary to allow patients to effectively use the information in adjusting their life plans. Similarly, respecting a patient's refusal of treatment maximizes autonomy only if a balanced and thorough deliberation precedes the decision. Again, the principle suggests that physicians observed strict confidentiality, but the more complex moral challenge is to confidential information in a way that will help to give the patient more freedom. Thus, the doctor can help can keep a patient's report on family's dynamics private and still use it to modify attitudes or actions of family members that inhibit the patient's control. At its root, illness is an evil primarily because it compromises our efforts to control our lives. Thus, we must preserve an understanding of the physician's art that transcends non interference and addresses this fundamental reality. This is the end of Why Doctors Should Intervene by Terrence F. Ackerman, found in the Hastings Center Report, Volume 12, Number 4, published August 1982 by the Hastings Center, read by Rigo Martinez.